Gastroparesis is where the stomach doesn't necessarily function as well as it should. It doesn't grind up food and push it through into the small bowel as quickly as it should. Patients a lot of times will complain of bloating, nausea, vomiting, abdominal pain. Depending on the type of gastroparesis you're dealing with, being diabetic gastroparesis versus idiopathic gastroparesis versus narcotic is the way we treat it. With diabetic gastroparesis, there's a couple procedures that can be offered. One is what we call pyloroplasty, where we go in and we cut the muscle between the stomach and the first part of the small bowel called the duodenum. That can either be done endoscopically, so no incisions on the belly, but a scope down the throat, where we go in and we cut that muscle endoscopically. That's called a POEM, or endoscopic pyloromyotomy. The other one can be done laparoscopically with tiny incisions, where we do it through laparoscopic ports with long instruments and a long camera with a lighted tube on the end of it. And sometimes we actually skip the pyloromyotomy in diabetic gastroparesis and we put in what we call a gastric stimulator. And that's this implantable device that helps to stimulate the stomach function and squeezing in order for it to help empty. With idiopathic, we usually start with a pyloromyotomy or pyloroplasty, just like we talked about before with the either endoscopic approach or laparoscopic approach. And we can move on to other techniques after that. But it really takes the right patient and expectations set to begin with in order to know exactly where to head with gastroparesis.